Alright, so welcome to this short video on our abdominal pain case-based discussion. This is for parts 2A and B of the Caroline series. So what I'd like to do in this video then is take you through my answers to these questions. This is one of our case-based discussion sort of case studies that was written by Mary Cavill, who has subsequently left our team. And I thought it would be interesting for me as module leader to actually do the work as an example of how to approach this. So I'm going to take you to the learning outcomes for this session then. So this is a case study that I actually was unfamiliar with. And I thought it would be a good opportunity for me to actually have a go at this this type of work to see, well, how does it feel to do this? What's the process that we're going to go through in order to answer these questions? So I'm going to give you my answers to some of these questions, and it might be interesting to see, well, what sort of discussion does this generate? But in particular, I wanted to offer an example of how to approach this type of work. So obviously we're running this sort of asynchronously at the moment, that we're asking you guys to spend some time in class doing this work, and then I'm offering feedback. So this is my feedback video for all of the videos that I've watched of yours. So thank you for doing those in class. But in particular, I wanted to offer an example of how to approach this. Obviously, I'm using PowerPoint, and that is possible through Flipgrid. It means recording the video and then uploading it to Flipgrid. But I wanted to offer some examples of how to approach this sort of more formal presentation style, where I'll be using my references and presenting them orally, as well as showing them on the screen. So the first of these questions then asks us to, well, it says, based on your examination findings, we're skipping straight to the exam because we've already looked at the history in part 1. So based on your examination findings, identify the key information of Caroline's case and outline your current hypothesis. Right, so as I just said, you've had the opportunity to look at the history information in part 1, although I know that for you guys watching this, we're kind of doing things a little bit back to front, that we've ended up looking at this part 2 first, but you've got the information for the history anyway. So based on our examination findings then, we know that she has sinus tachycardia with a heartbeat of 110 beats per minute. She has pyrexia, that she's got this temperature of 38.3. We have some abnormalities on urinalysis and some striae noted on the suprapubic region, with abdominal tenderness over the suprapubic region, with some right iliac fossa involuntary guarding. She's also got some vaginal discharge and inflammation, and it was a difficult internal vaginal examination due to discomfort and the volume of discharge present in the vagina. So that takes us on to our current hypotheses. Now the way that this question's been worded, I've interpreted that as it's asking for differential diagnoses. So I've offered 5 differential diagnoses here. So this implies that we're using the hypothetico-deductive model of reasoning, which I'll go into shortly because we're going to apply that to our next answer to one of these questions. As you can see, I've got this from DeSapri 20, I believe that's 2019. My video is just covering that up at the moment, but I do believe that that's DeSapri 2019. Offers some differential diagnoses in their discussion of pelvic inflammatory disease. I have used the information from the history and from the examination to offer this list of differentials, and I believe that at the top of my list is pelvic inflammatory disease. Some of the reasons for that are that, well, I think that the pyrexia is indicative of an inflammatory or infected process. There's obviously a systemic response to that she has sinus tachycardia. This urinalysis is also suggestive of some urinary tract or possibly GUM infection, the fact that she has some vaginal discharge present, and that it was a difficult internal exam, for me all helps me to hypothesize that it is very likely to be pelvic inflammatory disease, which is an umbrella term that captures several infective processes of the upper genitourinary tract of females. However, some of the important differentials, as I said before, of DeSapri, I'm sure that's 2019, some of these important differentials then are appendicitis, that we have involuntary guarding over the right iliac fossa, which is suggestive of some localized peritonitis, that we know that involuntary guarding is caused by inflammation of the peritoneum, which means that it's firm, and that there should be this sort of well demarcated area around the right iliac fossa. Right iliac fossa tenderness as well would be suggestive of appendicitis. You can also get suprapubic pain. There's no sort of typical presentation of appendicitis, not really. One of the other things that we could consider is an adnexal tumour, but I think that that's less likely because that would be usually asymptomatic. They're usually sort of found as sort of collateral when patients are being investigated for something else. It could potentially be endometriosis or an ectopic pregnancy, and in particular I want to think about ectopic pregnancy because that needs to be on our list to rule out, because especially if it ruptures, a ruptured ectopic pregnancy obviously is a life-threatening emergency, and so that needs to be ruled out as a priority. Okay, so going into making a list of any further information that I need to confirm or refute my hypotheses. So again, using ultrasound scanning would be the first investigation of choice. Now this is supported by Agrawal 2017 and NICE 2019, that they are suggestive of ultrasonography being, transabdominal ultrasonography being the investigation of choice after we've done our history and examination. That would allow us to potentially rule in or out several of our differential diagnoses. For example, if ultrasound confirmed a normal appendix, and then we can rule that out. And I know that as we progress through the case, we do get the ultrasound results shortly anyway. But this is the imaging of choice in suspected pelvic inflammatory disease, especially when there's ambiguity or unexplained clinical findings. So a pelvic inflammatory disease, as I said, can be one of several specific diagnoses. That it's an umbrella term, and it's going to include tubo-ovarian abscess, which, as I said before, once we get to our actual ultrasound scan results for Caroline, we'll see that that is highly suggestive of tubo-ovarian abscess. We could consider an MRI, however, according to NICE 2019, it's not used routinely. It's more accurate than ultrasonography, so I guess it's going to come down to individual trust policy and engagement with radiology departments to decide that. I guess the benefits of ultrasound are that it's less traumatic for patients, and it's obviously cheaper and probably more easily accessible. I'm pretty sure that you can get an ultrasound scan pretty quickly in A&E. We want to use a pregnancy test, as I said before, that if Caroline has an ectopic pregnancy, then we need to rule that out as a priority. Given that she's presenting with an acute abdomen, she's becoming acutely unwell, we need to rule out ruptured ectopic pregnancy in particular. I'd also want to do some blood tests, and again, as we progress through the case, we'll see that we do get urea and electrolytes and a full blood count for Caroline. So these are going to be important because, there's the signs of systemic illness. Our urea and electrolytes are going to be useful for being able to tell if she's at risk of an acute kidney injury, and full blood count will help us to differentiate things like any sort of internal hemorrhage, that sort of thing. So next we need to discuss my ACP approach to the management of Caroline's condition based on my refined hypothesis. So at this point then, my refined hypothesis is that I believe she has complications, a complicated pelvic inflammatory disease. Obviously at this point we haven't got the ultrasound scan yet, so I'm being less specific than, I'm not sort of at this stage saying, well, it's tubo-ovarian cancer, but I think that everything that we've seen so far is placing pelvic inflammatory disease, a complicated pelvic inflammatory disease, at the top of my list. And we haven't got the pregnancy test yet either, so I want ectopic pregnancy definitely to be on there. Appendicitis is quite high on that list as well. But my ACP approach then is using Barrows and Pickle 1991. I really like their method, and I've liked implementing their method ever since I discovered it as a trainee advanced clinical practitioner. I think that they demonstrate a method that incorporates pattern recognition and hypothesis testing, which I think is a very realistic approach. That theoretically we can kind of separate hypothesis testing and pattern recognition, but realistically, and as sort of pragmatic clinicians, we'll use a little bit of both. And I think that personally, undertaking this piece of work actually was challenging, and I enjoyed the challenge because I have had next to nothing to do with gynecological problems in the past. The majority of my acute background, at least as an ACP, was in ear, nose and throat, so abdominal stuff isn't really my specialty either, as much as I can apply it to primary care settings. And I do have an extensive surgical care background, but prior to becoming a trainee ACP. So I was reliant quite heavily on hypothesis testing and using that hypothetico-deductive model of reasoning. And I found it quite intimidating at first, if I'm honest, because obviously I want to be able to demonstrate a good way of doing this and demonstrate that I've hopefully got the answer right for you guys. So it was an important learning exercise for me to actually make sure that I felt confident that, yeah, I feel as though I've deduced the most likely diagnosis for this case. And I think that relying on hypothesis testing is exactly how we would do that in practice. If you're faced with something new that you're not too sure about, we can't really use pattern recognition very much. We've got to be reliant more on hypothesis testing. So what should be the next steps for Caroline's care? Let's take a quick drink. I want to communicate my working diagnosis with her and make sure that she is understanding the information I'm giving to her and that she's involved in the consultation, because at this point I haven't referred her to secondary care yet. So by using clear communication skills and using active listening, including facilitating the patient to understand and facilitating my own understanding of her perspective as well. So I'm using Neighbour 2006. So this is from Neighbour's The Inner Consultation here, that he discusses the use of summarising as a way to demonstrate that I'm listening and understanding her perspective, and using ideas, concerns and expectations as well as a useful tool to understand Caroline's perspective on the consultation and her care as we move out of primary care and into an emergency care setting. Offering her time for questions as well is going to be really important for her to be able to feel as though she's got the information that she deems important. And making sure that I use good safety netting as well, which again comes from Neighbour 2016. That I'd say that my typical approach to consultations is that I use primarily the Calgary-Cambridge model, which obviously I'm not referencing here, so I'm just thinking about this now actually. But I do like to use elements of Neighbour as well, and I think that Neighbour's use of safety netting is really valuable, making sure that as Caroline leaves my care, that she understands that what the next steps are, and that there's sort of mechanisms in place to ensure that her care continues. Another element of Neighbour's model that I've not mentioned on here that I sort of really advocate is his housekeeping stage, where we care for ourselves as clinicians as well, which isn't part of the Calgary-Cambridge model. But we're going to refer Caroline to secondary care. I think that we've got some clear indications there. She has an acute worsening abdominal pain, so this is a pain that's gradually, it's steadily gotten worse over a couple of days, and certainly shows no sign of getting better. She has involuntary guarding that we've already discussed, and so this to me demonstrates a potential developing peritonitis. She's got some signs of systemic illness with her pyrexia and tachycardia. And at this point, we're unable to rule out potentially life-threatening causes, so appendicitis and ruptured ectopic pregnancy. Even, I mean, as I said before, as we go on to the more accurate working diagnosis of tubo-ovarian abscess, that in itself is going to become a life-threatening illness if it isn't treated properly. We also need to consider some social aspects as well. So who's caring for Alex, her son, while she's potentially going to be admitted to hospital? So Caroline's a lady who lives alone. I don't know if she's still in touch with her husband, if she can sort of trust him to look after her son. So that's something that we need to consider at this time. So we're moving into part 2b then. This is when Caroline's reviewed in the emergency care setting. So question 1's asking us to review the blood results and the physical findings. So I'm going to choose 2 or 3 of these tests and explore their uses. I've chosen 2. I've chosen the renal function blood test, so the urea and electrolytes, and the CRP as well, so C-reactive protein. So starting with the renal blood test then. Now so I picked up on something within the case study here that is probably unintentional, and even as module leader I've overlooked this. So with creatinine we haven't actually given, and the same for urea as well actually, so we should be giving you what the units are rather than just numbers, so I'll have to have a look at that myself. But what we need to know the normal ranges for the lab. So this is what I've found as I'm reading about these. So I've looked at SINA 2019, and all the references for this are in my reference list at the end of the presentation. But for each, if we're given a lab result, we need to know what the normal ranges are for that lab, because they're going to be different for different laboratories depending on which sort of specific test they're using and the way that lab conducts them. But it's likely that this creatinine in particular, creatinine and urea are both increased. And according to SINA 2019, and that is putting her at risk of an acute kidney injury. Moving into CRP then, so our C-reactive protein is a non-specific marker of inflammation, and we've included this. So this again, we need to know what the units are and what the normal ranges are for the lab, but this is likely to be raised. I mean, that's fairly obvious, isn't it? So this helps us to rule in complicated pelvic inflammatory disease and appendicitis, because they're both inflammatory infective processes. But in terms of our sort of hypotheses formation at this stage, I would say that this offers limited value as our clinical diagnosis, where we've already recognised that there's inflammatory infective processes going on because of our even just with the basics of her tachycardia and pyrexia. But going back to what we said about the guarding, the involuntary guarding, and her worsening abdominal pain, I'd say that we've already put together a clinical picture that there's inflammatory processes going on here. So I'm not sure what this is really adding at this stage. Let me know in the comments if you know a little bit more about that than I do, because I'd be really interested in that. That would be great, thank you. So we're continuing with our review in the emergency care then. So questions B and C at this stage are asking what action is required, and we're going to prioritise our actions. And are there any additional blood tests that might be beneficial here? So our actions are forming a working diagnosis of pelvic inflammatory disease with tubo-ovarian abscess, and that's based on our ultrasound scan findings at this point. I'm not sure if she's had any analgesia up to this point as well, so I think that is going to be a priority for me. That we need to make sure that she's comfortable and at ease as well. I'm actually just thinking at this point now, we maybe need to ease any anxieties. So first of all, addressing her physical pain and making sure that she's not overly anxious while she's in the department is going to be really important. We need to refer her to the surgical team, which would need to be prioritised. Communicating with Caroline, making sure that she understands what the likely diagnosis is. Now we're only really going to confirm this on surgical intervention. we need to start antibiotics. Now, again, my camera's blocking out my references there, but we'll talk about antibiotics on the next few slides anyway. They need to be started as a priority. Or equally, we need to monitor fluid balance. So in the case study, it's saying that we've made her nil by mouth, essentially. She also we've identified that she's at risk of acute kidney injury, so we need to monitor what's going in and what's coming out. So she's going to also need some intravenous fluids, isn't she? Regular observations as per the EWS, and again, sorry, my video is blocking this, but I remember that I calculated her as being scoring 5 on the National Early Warning Score chart. So I think she needs hourly physiological observations in place. And we also need to consider our local sepsis pathway as well. So further blood tests are certainly going to include serum lactate at this point, so that we can sort of keep her safe from any evolving sepsis. So our antimicrobial and pharmacological approaches then. So it says next steps for Caroline's care, and the case study said we can consider a few things. Now, I'm trying to keep this video fairly concise, so I'm just going to focus on antimicrobial therapies. Now, our goals here then are to cover a broad spectrum of common organisms that are likely to cause pelvic inflammatory disease. So that is going to potentially include chlamydia and gonorrhea. So what I'm referencing here then is the BASH guidelines from 2019. I can't remember exactly what that stands for now, it's in my references at the end, but also the BNF for 2021. So again, my actual clinical experience with gynecological problems is practically zero, so I had to look this up theoretically. And again, I'd like to hear from you guys if what do you make of this then? Let me know in the comments. But what I'm suggesting is that IV ceftriaxone 2 grams once daily, plus intravenous doxycycline 100 milligrams twice daily, according to the BASH guidelines. Now, these actually contradict to an extent the BNF. They warn that ceftriaxone actually isn't licensed for use in peripheral pelvic inflammatory disease. So we'd be using ceftriaxone off license, which we're able to do as prescribers. That's just something that we need to be aware of if we're doing that. But there does seem to be a decent evidence base provided by these BASH guidelines from 2019. Excuse me. So we're moving on to just a bit of reflective learning then. So I thought that this was a really interesting case, and it was interesting for me to learn more about gynecological emergencies. As I've said before, this isn't my background. This is a case study that was written by Mary, but I've really enjoyed working the problem from scratch. So I get some insight into what we're asking you guys to do. I've enjoyed researching it and offering my references, and I hope that I've demonstrated how to orally deliver the references, that it's useful to see them on screen, and you can be thinking ahead to, well, this is how I can approach my case study at the end of the module. Also, it would be a good opportunity for you guys to think about, well, how are we making the most of these group sessions while we're having to use this asynchronous approach to practice our clinical decision making, to work out our way through these case-based discussion series. How can we use that time in the classroom when you're in your groups, you've got that good sort of social learning going on? How can you make the most of that? And so I think try to be a bit more creative. Can you do something a bit like this? Can you ensure that you're referencing properly rather than just saying CKS guidelines say this? Offer the date, show what your reference is, produce a reference list to support the work that you're doing for this. Because I think that could be a really positive and interesting way to approach this. So hopefully this has helped. Please let me know in the comments what you think of this, and if there's anything that you want to add. I've really enjoyed watching your videos, and I'd really like to see you now sort of continue to improve those, continue to get them that little bit better each time, thinking about the quality of the work that we're producing. So thanks very much for watching, and I'm recording this on Tuesday, and I will see you guys tomorrow. Thanks a lot. Here's my references anyway. I'll make sure you've got the slides for this, and it'll not have my head in the way. So yeah, thanks a lot, guys.